Yes, I'm here. Can you hear me?
Yes, we can. Thank you. We've been having some technical problems with our last speaker, Dr. Schoenemann, but
I heard.
I hope we're all set now with you. Thank you for being with us, and before anything else happens, we'll have you start speaking.
Okay, I'll try to say everything important in the first 2 seconds. The only problem is I am not seeing my slides up here. Do you need to share some sort of permission with me or something? Hello?
Yeah.
We're bringing it up.
We're bringing it up now.
Okay.
Can you see it now?
I can see it now, but I need the, let me see, to advance.
Hi, David. This is Meredith, and if you just tell me when to advance the slide, I will do that.
Advance them for me?
Yes.
Okay, very good. So,
Okay.
So I'm gonna, great. So you'll be advancing for me, right? And you can hear me okay?
Yes, thank you.
Okay, great. So I was able, fortunately, to listen to the prior 2 presentations, which were great, and I think you'll see very complementary. I'm going to be talking about value of information analysis and the general question of whether it can help inform research priorities, but particularly about its use potentially in informing priorities for systematic reviews and, in your case, updating guidelines. I should say that the presentation I'm going to give is based on work that we originally did for ARC when we were asked by the evidence-based practice centers to comment on whether VOI or value of information analysis might be usable for prioritizing systematic review. So that'll be kind of my starting point, and I'll add to that, I think, with ideas relevant for what I think your question is. So let's go to the next slide. So we all know that doing research and updating guidelines is costly, and as a result, we have to choose carefully among topics. And systematic reviews or guideline implementation are less expensive than primary data collection, but obviously expensive enough that you can't either do all reviews or update guidelines all the time. So you need a way to prioritize. And value of information analysis is a strategy to try to provide some quantitative evidence of the value of research. And the question we really set out to try to understand better is whether this approach could inform priorities for systematic reviews or guideline developments. And there are a couple of key elements here that make this a real question. The first one is that value of information analysis itself is complex and costly compared to other prioritization approaches, such as subjective judgment and even well-organized systems and systematic reviews. And so you don't want to spend more money deciding whether to do a study than just to do a study. And so you have to be careful about the costs of these sort of analyses. But unfortunately, there are some newer approaches to performing value of information analyses that are less expensive and therefore can reduce some of the barriers. And I'm going to talk about some of those today, and then talk about how they might practically be used to inform priorities for systematic reviews, or in your case, some guideline development. So next slide. So I'm going to begin by talking about value of information analysis, lay out the theory and some of the tools for its practical application, and refer a little bit to some of the experience doing them. And then I'm going to turn to efforts to prioritize systematic reviews, which, I think will carry over to guidelines heavily. With current approaches that are used, a possible VOI framework to think about that, and I'll talk a little bit about some experience we have applying the framework. And then I'll conclude by talking about some implications for the use of VOI to inform priorities for systematic reviews, and then research priorities more generally. Okay, next slide. So the key background for all of this, of course, is really the tools of medical cost-effectiveness analysis, which for many years have been used to assess the value of medical treatments, and similarly, in some cases, medical decision-making, such as the information that comes from diagnostic tests. In the technology assessment literature, cost-effectiveness is the most common approach to thinking about this, where costs are measured in dollars and qualities or benefits in quality-adjusted life years, and as long as the ratio of cost to qualities is low enough, you say something is cost-effective and go ahead and do it. people over the past decade or two have become increasingly aware that the cost-effectiveness ratio itself can be a little bit misleading as to the ultimate importance of a decision, because it's a ratio and doesn't reflect scale. And so people have also come to look at other approaches. One of the most important recently has been what's called net health benefits. And what that does is look at the gain in health, for example, and qualities of some health intervention, and then subtract off the opportunity cost of the spending needed to get that benefit. So it's a net benefit in terms of health. It's very much analogous to cost-benefit analysis or net monetary benefit, which is a much more long-standing established strategy to do this, but many people aren't as comfortable with because it very explicitly puts a dollar value on health, which in the end you really need to do anyway for any of these approaches. But nevertheless, the health benefits approach is an important one. I emphasize this because the value of information techniques that have been used over the past decade or so to explore this area have emphasized these net health benefit frameworks or even net monetary benefit frameworks. Okay, next slide. So in thinking about value of information analysis, I find it very useful to think about research itself as providing value through the information it provides. And I think of this from a clinical decision-making perspective, a lot like a diagnostic test. You do a diagnostic test and you figure out whether someone's sick or healthy, and you always give them the right treatment once you've figured out whether it's sick or healthy. Whereas alternatively, if you don't test them, you don't know whether they're sick or healthy, and you have to make a guess. You either treat presumptively, in which case you sometimes overtreat, or you don't treat, in which case sometimes you fail to treat people who would benefit. And the difference in expected outcomes between the top branch, where you always do the right thing, and the bottom branch, where you take the best guess you can and, with some probability do the wrong thing, that's in essence the value of the diagnostic test. And the value of research concept is really exactly the same idea, except you're testing the quality of the knowledge you have, discovering it's true or not true, and then doing the right thing based on the truth, or taking a guess and making your best judgment in the presence of uncertainty and then suffering the consequences of sometimes making a mistake. So that's the sort of theory at the very most basic level. You can go on to the next slide. So this is just another way of saying the same thing, that without information, you make the best compromised choice, not knowing the true state of the world, i.e. whether the intervention is good or bad. And with some probability, you get the value of the compromised decision, given that it was a good thing to do. And in some probability, you get the value of the compromised decision, given that it was a bad thing to do. And that's the best you can do without information. With information, you discover the true state of the world. With probability P, it was a good thing to do. With probability 1 minus P, it was a bad thing to do. And you always do the right thing. And the value of information is essentially the difference in the expected outcome with information, always doing the right thing, versus the expected outcome without information. And the algebra that follows below just breaks that down according to whether the intervention was the right thing to do or not the right thing to do. And when you rearrange all those terms, what you realize is that, in essence, what value of information doing is calculating the probability that the compromised choice you made might be wrong, and multiplying that by the value of correcting that compromise, given that that compromise was a mistake. Okay? So there are really just two key terms here. How important is the decision you might have made wrong? And how likely is it that you made that wrong decision? And those two ideas essentially will carry through everything we're going to talk about in thinking about this framework. So next slide. Okay, now in doing those calculations, you need a fair bit of information. And the ideal calculation really is what's shown in the top line here, which is the expected value of information, which is the expected gain in welfare from research. And in order to know that, you need to know the burden of illness. So, what's the harm you're considering? Your priors, how likely is it before you do research that, something is or isn't the right decision? And then the posteriors after you do the research. The study then makes it more clear what the right thing to do is, and you make the best judgment. So that's the information you required, and that's a lot of information, actually. And it's particularly hard to really fully characterize, for example, what you're going to learn from research. But this assumes that you can do that. Because of those high information requirements, one thing that many people have done is look for ways to at least bound that value of information calculation with less information. So one of the most commonly used concepts in value of information analysis is the expected value of perfect information. And in this case, you still need information on the burden of illness and priors, how likely various true states of the world are. But you don't need information on the actual state of the world because you're assuming that you get the true, complete information about the true state of the world by your study. So it's a perfect study. And so once you've characterized the prior, the posterior is essentially fully becomes irrelevant because you're gonna identify all of the truth. So the problem with this, the advantage of this is it requires less information. The disadvantage is it provides an upper bound. If you read this literature, it is often very unclear about the fact that it is doing expected value of perfect information, and that implies that you've got an upper bound and you don't know how informative it is. It's an important thing to know as you think about these. There are some related ideas like the maximum value of information. You may not actually have full priors, but bounds on something. And the maximum value of these specific research is an extreme form of that, where you essentially are asking what would it be worth to get rid of an illness, which is very much like the old Rice sort of burden of illness calculations. So this is a hierarchy of estimates from at the very top, the most precise, at the bottom, the least precise, but also the easiest to implement. Okay, next slide. So let me try to talk through some of the methods that are used practically to do value of information analyses. So one key first concept is that value of information analysis is really modeling the population value of information. And it's written here as a sum over time of a bunch of terms, starting from the far right and working to the left. The individual value of information is essentially the value at the person level of resolving the uncertainty about what the right thing to do is. That's calculated in the sort of ways I described earlier. N is the number of people affected. I is how likely the information you collect is to be implemented. So if it's not used, it's really not very valuable. And then D is the durability of the information. And not very valuable, presumably, to do a study right now if a new study is going to be ready in a year, which is going to completely change everything. And then the beta is just a discount factor that describes this information is used over time, and value in the future may be worse than value today. So this is sort of an aggregate population level measure of value. So how do we actually calculate this? Well, most of the action really is on the value of the VOI term on the far right. So one strategy is to calculate value of information based on decision models. The individual level value of information is modeled with a classic decision tree, many of the examples of this sort of approach are in the United Kingdom. NICE has done this very often. One of the very first examples where they did this was Alzheimer's disease treatment. So let me go to the next slide and illustrate that. So the question really was, what was the value of acetylcholinesterase inhibitors? Should NICE be paying for them? And they start by building a classic Markov decision model where people have either mild, moderate, or severe dementia and then can progress to death from any of those states. So they build this model. They populate the parameters of the model with data from the literature after careful review of that, and they build that model. And go to the next slide. And from this model, they propagate the uncertainty in their estimates, looking at the incremental net benefit in terms of health or dollars, doesn't really matter which they do, at various intervals of use or various periods of use. And one of the key challenges, as it turns out, in the use of these medicines in Alzheimer's disease is the vast majority of studies were very short term. And so it turns out when they looked at these, if you look at sort of 24 weeks as the period over which the study, the benefits are being counted, it turns out that that's a very sharp spike, and it's mostly to the left of zero, meaning negative. So that on net, they conclude that if you're just looking at short-term value of these medications, there's really not a lot of uncertainty about whether they're of value, and they seem not to be that useful. But then when they analyzed a longer-term window, they had tremendous more uncertainty. And you can see there's a long right tail there with some likelihood that there could be really substantial benefit to these medications if used longer term. So that is sort of the first step in assessing value is there uncertainty. So go to the next slide. So here what they do is they combine the level of uncertainty, the likelihood that their decision would change, with measures of the magnitude of the benefit if they were changing. And what you can see is that for week 24, on the x-axis here, they have the value of the health outcome. And essentially, there's no value in doing additional research over a 24-week period because there's essentially no uncertainty according to their model. As you go to week 54, you see more uncertainty. As you go to 210 weeks, you see even more, and associated with that, even more value. Now, you'll notice in this these curves that are not just flat, that they have peaks, and that they go down on either side of those peaks. And the reason they go down on either side of those peaks is because as the monetary value of health becomes very large, you always want to do the treatment, so there's not much value in research. And conversely, when the monetary value of health is very small, you never want to do the study. So there's, again, less value in resolving it. So what you can see is that the decision rules here and guidance about funding reflects ultimately uncertainty and value together. And that's one of the big advantages of the framework. Go to the next slide. This uses that and is a study from some results from the same NICE study saying that if you were going to prioritize research in Alzheimer's disease, you'd really focus on efficacy duration. There are some lesser effects on relative risk reductions. Things like cost, utility is much less important. The really key parameter is how long does the effect last. So it helps you prioritize that as an issue within the broader context of studying these medications. So that's a nice thing about building a decision model. It lets you target particular parameters. Next slide. Let me turn to a second approach. Now, the advantage of the decision model approach, as I said, is you can drill deep into specific questions. The problem is you have to build a big, complicated decision model. So wouldn't it be nice if you could sort of do this without having to build those models? And this is where minimal modeling approaches come in. Essentially, what these involve is taking the individual level value of information, the uncertainty, almost directly from a clinical trial. So you have uncertainty and some probability that something is or is not beneficial based on that trial. It's a trial that typically follows things either long enough that you could get an intermediate endpoint and then you can build a more limited model, or follows them completely to the endpoint of the intervention. That's the no modeling approach. So you're basically taking the uncertainty almost directly or directly from the trial results itself. And I'll illustrate these with the Katie trial of atypical antipsychotics for limited modeling and a couple of examples in the no modeling approach. Let me just say, because I'll come back to it later, but it's on the slide, you can also bound some of these things with more limited data, such as burden of illness, but it's really not getting at the uncertainty element. So let's go back to the minimal modeling approaches. So next slide. So this is the limited modeling approach. And the example here that I chose was a study we did of the Katie trial, which compared atypical antipsychotics to profenazine, a neuroleptic, for patients with established schizophrenia. And this was funded by NIMH. And the major findings of the study were that the discontinuation rates were similar with the atypicals and with profenazine, but profenazine was a lot cheaper, so it was the cost-effective first-line treatment. And when this results came out, it was frequently discussed as part of coverage decisions, and some people even argued that the results should be considered definitive and we should just move away from the atypicals. And there were lots of payers happy to do this. And we wanted to review the sort of robustness of that result and whether, in fact, there was still value in studying atypicals versus traditional neuroleptics. So next slide. So these are some results that came from an original decision analysis done of the Katie trial. And the most striking things about this were that perfenazine was a lot cheaper than all the atypicals. And there really were no statistically significant differences in predicted qualities, except for risperidone, which seemed to have a lower quality-adjusted life expectancy than others. And there were critiques in the trial about whether it was, in fact, dosed too low, and that may be why. So I'm not even sure people believe that. But the conclusion of the people closest to the trial who looked at it was that the atypicals weren't better, maybe even worse, and were much more expensive. So let's try to evaluate that from a value of information perspective. So next slide. So this shows the uncertainty in the qualities associated with the atypicals and perfenazine. And you can see they basically all overlap each other except for one. That's the risperidone, which is to the left, so a little bit lower benefit. So what you can see here is that there's a lot of uncertainty. Even though these spikes are pretty narrow in terms of qualities, there's a lot of overlap in them. And then the question is, what's the social welfare value of resolving that uncertainty? So go to the next slide. So this is the same thing for costs. You'll see uncertainty here too. Perfenazine skewed towards the left. It's cheaper, but again, big tails in all of these. Next slide. Okay, so this is the calculation based on that sort of population health equation I showed you of the value of resolving that uncertainty. And it's really sort of an extraordinary number. This is the aggregate value for the prevalent cohort of people with schizophrenia today and the incident cohorts up through 2036. And what you see is that the total value to each incident cohort is about $6.6 billion. The total value of the prevalent in the next 20 incident cohorts is $342 billion. So what this tells you is this is a wildly important public health decision. And that might not have been obvious from what seemed like narrow confidence intervals around those episodes. But once you understand the prevalence of schizophrenia and its durability, you understand how this matters. And this is the value, I think, of a value of information framework, reflecting both uncertainty and population health value. Next slide. This is another nice use of value of information analysis, which is that you can use it to estimate the value of studies at various sizes and calculate the optimal sample size from a maximizing population health value, net of cost. And what's interesting in these calculations is that it suggests that the optimal study sizes for these drugs are sort of 20 to 25,000 people. And that's just a striking contrast from Katie, which was really a sample size measured in the hundreds, not in the thousands. So I think these can be very illuminative examples. Go to the next slide. Very briefly, the no modeling approach is here what you do is you look for interventions where you can see an intervention, a randomized trial where people are randomized to the two treatments and followed essentially to completion. In this case, azithromycin versus augmentin for acute sinusitis. The basic RCT done on this showed that azithromycin did a little better within 5 days in terms of resolving symptoms, but by 28 days, there was no difference. And so the trial captured, through all its measurements, the sort of full distribution of that outcome. Next slide. This just shows that from the survival curves in the study, you can calculate the expected outcomes of the two arms. This is days of symptoms, which for azithromycin was somewhat lower than for augmentin, the cheaper alternative, and that gives you a measure of the expected benefit. On the next slide, you can see that we calculate a net benefit calculation where we subtract out the value, which we put in dollars, of the days of symptom resolution. We subtract off from that the difference in cost. Again, azithromycin being more effective.
Yeah, I just got cut off. I don't know why that was.
Hello.
I think they might have sort of signed us each up for Windows and not anticipating that they would be late.
That's our indirect way of cutting you off. I'm joking, but we can hear you both now. So Dr.
Oh,
Meltzer,
okay.
would you like to
Okay,
continue?
that's great. Do you have slides up?
Yes, and then we'll work on reconnecting this.
Okay, that's fine. I can't see. So are you on the VOI results slide?
We are, yes, we are. VOI
Yep.
results.
Okay, perfect. So I'll just summarize. Basically, what we discover is that if you ignore cost, there's relatively little value of additional study because we're pretty sure that azithromycin is better. Once you include costs, there's much more value of research because the net benefit accounting for costs is smaller. So it gives you an idea of sort of quantifying the value of these things. Let me turn to another method that I think is very useful, and this is what we call conceptual value of information. And essentially, it goes back to this population health equation that includes the individual level value of information, the number of people, how likely something is to be implemented, and how durable it's likely to be. And the observation is that as a first-order approximation, these are really multiplicative effects. So if there's no uncertainty in something or no likelihood that you're going to change the uncertainty, no value in doing research. If almost no one is affected by the decision, no value in doing research. If something's not going to be implemented, even if you make a recommendation or get more information, no value in research. If there's new information coming very soon that's going to trump whatever you do, no value in research. I think of this as a very valuable checklist, and it has a quantitative element to it as well that allows you to think about value in that context. So if you go to the next slide, it says Quantitative VOI Estimates. That lays out a series of VOI studies that actually have put a dollar value on various studies. And I just can't help but point out that sort of the two largest numbers on this table are psychiatric things. I suspect that if you looked at sort of nutrition, the value of information.
We'll try it once more.
We agree with you.
Okay, great. I don't know where I got cut off. I think. Can you tell me where you last heard me?
Well, we're on a slide called No Modeling about pancreatic cancer.
Okay, fine. We'll go back to there. Okay, great. So go to the next slide. It says conceptual value of information. So this is another approach that can be used, and essentially goes back to this population health model of the value of information based on the individual level value of information on the far right, the number of people affected, how likely something is to be implemented, and how durable it's likely to be. And the essential observation is this is a multiplicative sort of relationship, where if there's no likelihood of changing the decision based on resolving uncertainty, then there's no value of information. If almost no one is affected, there's no value of information. If something's not going to be implemented, even if you get more information on it, there's no value of information. Or if there's information that's not going to be very durable because there are new alternatives coming in the future, then there's not going to be much. So this becomes a really valuable checklist to think through as you decide which studies just really aren't worth doing. Assuming none of those things is the case, it's very useful on the next slide to think about quantitative estimates of VOI. And you can see here a series of studies where the methods have been normalized to be comparable to each other. And one interesting thing to note is that at the very bottom of the list with the highest values are things in mental health. I suspect some public health interventions could be here as well because of just the large number of people who are affected by them. The next slide is just sort of summarizing again some of the advantages and disadvantages of the full modeling, the limited modeling, and no modeling approaches. And there's a reference here to a paper that goes in much more detail about these. As I said, they really differ significantly in the cost of utilization, and I'll come back to that in a minute. If you go to the next slide, this is talking about using value of information analysis in particular to prioritize the suspect views. And our goal in doing this for ARC was to try to develop an algorithm that would allow us to decide which approaches were best to use in various settings, and to review the processes used to set priorities for a variety of different decision-making bodies, and try our algorithm against some ARC efforts to prioritize things. So if you go to the next slide that says algorithm, this sort of describes the idea. It's, again, this sort of population health idea. what you see here is that it depends on the sort of net benefit, likelihood of value of information and implementation, and then also durability and the number of people affected. But subtracted off from that is the cost of the intervention. And if you go to the next slide, this lists the approaches that I've described from least expensive to most expensive. The least expensive is conceptual VOI, which is almost a checklist. Minimal modeling, works only if you have the right type of data from a study, and an intervention is a short-term one. A full modeling approach, is costly if you have to build a model. And the maximal modeling approach you haven't heard about yet, but I'll tell you about now. And the idea here is that you build a model not to answer one question, but to answer many questions. And so it's actually a very costly investment. You can, but then you can do value of information analysis for a whole variety of topics. So if you go to the next slide, you can see an example of the type of thing I'm thinking about, the coronary heart disease policy model that was originally developed by Milt Weinstein and colleagues, and Lee Goldman has stayed with that over many years. And it's essentially an encompassing model of cardiovascular disease burden in the U.S. And another example on the next slide is the CDC model of diabetes. Other examples could include some of the CISNET models that NCI has developed around cancer screening. And the point is, once you've got a decision model like this.
So I apologize. I just learned that there is a problem with WebEx system-wide.
System-wide?
Yeah, so it's something that we can control or that we've been doing.
Maybe send in that message. I think it's going to be hard to do questions and answers
I agree. So why don't we ask the committee members to please write down your questions, and then we will send those to the speakers. We'll ask them to submit their responses to us, and then we can post those onto our website for the record.
Right.
So, Rob, do you want to break for lunch?
So I think it's time now to, it will be the best time to break for lunch. Lunch is, there is lunch downstairs, can be purchased at the refectory for everybody in this room. Thanks very much. And we can reconvene at what time? 12:15?
1:15.
1:15. I meant 1:15 back in the room. Thank you.
Thanks.